CAR T-cell therapy is currently approved by the FDA for the treatment of patients with large B-cell lymphoma. They relapse after frontline chemoimmunotherapy, so in second line, and 3 products are approved in third line. Yescarta is one of the most active but also toxic CAR T-cell products, due most likely to the co-stimulatory domain, which is CD28, as compared to 4-1BB, which is instead used by Breyanzi and Kymriah. As a consequence, when we compare Yescarta to the other 2 products, we see a higher rate of specific side effects, particularly neurotoxicity. And really, neurotoxicity is what is currently limiting the use of Yescarta in elderly patients, patients with comorbid health conditions, and most importantly, the use of Yescarta in the outpatient setting. Now, we have been trying over the last few years to understand why these patients develop neurotoxicity, whose frequency with Yescarta and large B-cell lymphoma can be as high as 60% of patients. Some translational data show that these patients have a very high levels of interleukin-1 that tends to be produced by either CAR T cells or monocytes and macrophages the first 7 days after infusion. And there are some preclinical data showing that if we try to target interleukin-1 with an interleukin-1 receptor antagonist called Anakinra, currently approved by the FDA for rheumatoid arthritis, in preclinical models, we are able to suppress neurotoxicity. So based on this data, we came up with this investigator-initiated trial where we use Anakinra at 2 different dose levels as a prophylactic strategy to prevent neurotoxicity. Anakinra was given on day 0, starting 6 hours before CAR T-cell infusion, twice a day for overall 7 days, either 100 milligrams or 200 milligrams twice a day. And we completed the study, and we also identified a contemporaneous cohort of patients that we matched to the study population, looking into tumor burden with a very sophisticated parameter called TMTV, or total metabolic tumor volume. So when comparing patients who receive Yescarta plus Anakinra to a matched contemporaneous cohort, the rate of neurotoxicity was more than half. This is very important because Anakinra seems to be very promising, as it may completely change the paradigm, and hopefully by even increasing further the dose of Anakinra, we may go up to even 200 times a day, we may be able to start to provide this very effective treatment strategy to older patients, frail patients, and most importantly, we could be able to provide it in the outpatient setting.